Good afternoon, everyone, and welcome back to the Massey Community Cancer Forum, where cancer community and conversations connect. This month is the Men's Health Month edition. I'm truly grateful to see you here for this month's Community Cancer Forum focused on men's health, a topic that too often stays quiet, even though it touches every family, every neighborhood, every generation. Today is about changing that. Men in our communities carry so much responsibility, pressure, and expectations. And sometimes that means putting your own health last. But your health matters, your presence matters, and taking time to learn, ask questions, and take actions is one of the strongest things you can do for yourself and the people who love you. Today, we're creating a space where we can talk about cancer risk, screenings, prevention, and steps that men can take to live longer, healthier lives. Whether you're here for yourself, a brother, a partner, a father, or even a friend, I'm here to tell you you're in the right place. So, with that being said, let's get this form on the road to connect. So, again, just want to make sure because I will be remiss if I didn't announce this. June is National Cancer Survivor Month. So, we just want to take a moment to celebrate our cancer survivors, their caregivers, and everybody surrounded and connected. Thank you for your fight. Again, June is National Cancer Survivor Month. Now, I have the pleasure of introducing our wonderful speaker. So, before we begin, today's conversation on men's health and cancer, I'm honored to introduce our presenter, a rising leader in oncology who brings both expertise and a genuine passion for the work. Today's speaker is Dr. Melson, a young medical oncologist whose focus includes urological cancers. And even in his early career, he has already earned a reputation for his commitment to patient education, community engagement, and making complex information easy to understand. He's especially excited about today's session. So, with all that being said, please join me in welcoming Dr. Melson, who is here to guide us through what every man and every family should know about cancer risk, prevention, and early detection when it comes to men's health. Thank you, Dr. Melson.
Yeah, great. Thank you so much. I really appreciate y'all inviting me and giving me the chance to meet with y'all today. All right, so it is Men's Health Month, and so today just want to take a little bit of time to talk about cancer and specifically cancers that are have a significant burden on men's health and are unique to men. I am a medical oncologist to help take care of folks with urologic cancers here at Massey. For our talk today, definitely going to try to get through the first three, and depending on how things are moving, may touch on number four, but primarily want to review cancers in men, looking at big picture incidence, mortality. What are those highest risk cancers, and what can we do in terms of screening for them to detect them early, prevent negative impacts from those cancers. Then I'm going to spend a little bit of time talking about prostate cancer, and then a little bit of time talking about testicular cancers. We'll really try to get through the first three, and then we can talk about androgen deprivation therapy, which is a form of treatment for prostate cancer if we have the time. So from a very, very high level, cancer is the second leading cause of death in the United States for men, second behind heart disease. And so while I'm really going to focus on cancer today, I do think it is important to emphasize that heart disease and cancer are really profound in terms of the impact on men's overall health. And so focusing on cancer today, I don't want to minimize the importance of heart disease or things that can be done to decrease the risk of heart disease. So that's probably for another day. Today we'll be focusing on cancer's impact on men. So I have here two lists. This is data from the American Cancer Society looking at the number of cases of each type of cancer diagnosed in a year in the United States on the left, and the number of deaths attributable to those cancers in the United States per year on the right. And if you look at the left side of the screen, the top three types of cancer diagnosed in men in the United States are prostate cancer, lung cancer, and colorectal cancer. In the US, For example, over 300,000 cases of prostate cancer diagnosed a year, over 100,000 cases of lung cancer diagnosed in a year. Translating that into what it means in the state of Virginia, that means somewhere around 9,000 cases of prostate cancer a year in the state of Virginia alone. If you take those top three, they account for about half of all cancer diagnoses in men each year. So prostate, lung, and colorectal cancer are really a main three when it comes to impact on men's health overall. Now, there are many, many other types of cancer that have a meaningful impact on men's health and men's lives, but I am going to really focus in on those top three today. If you look over the past several decades, I think we are getting better at treating these types of cancer. And that can be seen in both a decrease in the incidence of certain types of cancer, like lung cancer and colorectal cancer, where I think we are having better recognition of risk factors for those cancers and managing those risk factors. And then also interventions like screening to detect them early, identify cancer when it is treatable and curable. And changes in incidence and in our ability to manage these cancers is reflected in improving mortality. So the mortality rate from cancers overall have been decreasing over the past several decades as we've gotten better at early detection through screening and getting better with our treatments. Now, if you look at those top three cancers in men, lung cancer, colorectal cancer, and prostate cancer, each of those three have important risk factors that we should be aware of and have familiarity with. And each of those three also have potential screening options, standard ways for us to detect these cancers early and better manage them. So for lung cancer, cigarette smoking is the primary risk factor. Over 80% of cases are associated with cigarette smoking. And for those who have a smoking history, a screening CT scan each year is an option starting at age 50, trying to detect lung cancer early before it has a chance to spread. Similarly, colorectal cancer has a long list of potential risk factors. Some are out of our control, like family history or other medical issues like inflammatory bowel disease. Other things are potentially in our control. Composition of diet, body weight, tobacco, alcohol use. And there has been a shift as we're seeing more cases of colon cancer diagnosed earlier, of starting that screening process for colorectal cancer early. Guidelines now say for an average risk individual, you should think about screening starting at age 45. Although if someone has a family history or another reason to think that you might be at increased risk, colorectal cancer screening can start earlier. I think a key point with colorectal cancer is that if you screen with a colonoscopy, colonoscopy can detect an existing cancer, but colonoscopy also has the ability to treat a precancerous lesion. So it can be screening and prevention at the same time. I'm not going to dwell much more on lung cancer or colorectal cancer. I know that there have been presentations at the forum here recently that went into those much more in depth. So really going to shift and focus more on prostate cancer moving forward. So prostate cancer. So the prostate is a male reproductive organ. It sits just below the bladder. In the United States, men have about a 1 in 8 lifetime risk of developing prostate cancer. And when a prostate cancer first develops, as an example, you can see the picture on the right here, usually a small tumor develops in the prostate gland itself. And our goal is to detect these prostate cancers when they are localized, when they're in the prostate and have not had the opportunity to spread somewhere else where they can be life-threatening. Something unique about prostate cancer is that many men with prostate cancer don't have any symptoms. Some men, if the tumor is in a specific location, can have urinary symptoms. Urinary function can be affected by cancer-causing obstruction, for example, but many men do not have any symptoms from the tumor at all, which is one reason screening becomes so important. So a key point about risk factors for prostate cancer is that many of the risk factors for prostate cancer are not in our control. They're not related to behavior like cigarette smoking. The primary risk factor is age. So prostate cancer is very rare before the age of 40. The incidence of prostate cancer reaches its peak, its highest point, somewhere around age 70 in the 60s or 70s. But that pattern differs between folks of different racial and ethnic groups. So in the United States, we see that prostate cancer incidence is highest among Black men compared to white or Hispanic men. And it's not only a higher incidence, but the risk of prostate cancer starts earlier. We see cases diagnosed at a younger age than we do in other racial and ethnic groups. There's also a very strong link between prostate cancer and family history. There are a number of genes that can be passed down generation to generation in families that have a strong association with prostate cancer. And so when we're thinking about early detection and screening, understanding how these potential risk factors affect one person's individual risk are very important to tailor your approach to screening, figure out how to best be proactive for your health from a prostate cancer standpoint. I think this figure does a really good job of illustrating that earlier onset in terms of incidence and the higher peak, the higher incidence rate for Black men. So this is a figure showing the incidence rate, how often prostate cancer is diagnosed among different age groups. And so you can see that really before the age of 40, prostate cancer diagnosis is very uncommon, very rare. For most groups, the peak in the incidence rate is right around 70 years of age. But for Black men who are in this line with the red squares here, you can see that the peak is higher, the peak is a little earlier, and this curve takes off sooner. So whereas other groups have really low incidence rates through the 40s and then sort of takes off as you pass 50, that takeoff point is earlier for Black men. The vast majority, probably 80+% of patients who are found to have a prostate cancer have organ confined or localized disease at the time of diagnosis. So that means there is a prostate cancer in the prostate gland itself. It has not yet found its way to any lymph nodes or any distant part of the body. And if a prostate cancer is localized, there's a very high likelihood of cure with treatment. And that's really what we're going for with screening, is identify a cancer when it is in a curable state and then get the appropriate treatment to cure it. We contrast that with folks who are diagnosed with advanced prostate cancer, distant metastatic disease, a cancer that started in the prostate but has spread to the bones or the lungs somewhere far away in the body. We have treatments that can help control the cancer, manage it, and those folks often do well for many years. And those are most of the folks I'm taking care of in clinic are folks with advanced prostate cancer. But I would much rather have these men be screened appropriately, have the cancer diagnosed and managed early before it gets to the point where they have to come see me. Prostate cancer treatment can look very different depending on the specific circumstances. So for example, if someone has a localized prostate cancer with very low risk features, sometimes you don't need treatment right away. You can do what's called active surveillance. That means blood tests, that means scans every so often to monitor the cancer. And if it ever starts to show more aggressive features, then you can treat it. But that oftentimes can offer men many years without needing to go through prostate cancer treatment. Other localized prostate cancers that do need treatment at the time of diagnosis can be treated with a number of different approaches. For some men, the right treatment is surgery to remove the prostate or prostatectomy. For others, radiation is a good option. And then there are other considerations, newer techniques, including something called HIFU, which is a treatment modality we have at Massey that has recently been implemented here. If patients do have more advanced cancer, oftentimes we're talking about what we call hormone therapy or androgen deprivation therapy, or things like chemotherapy or radioligand therapy, all sorts of options to try to slow down and control these cancers, even if they've spread elsewhere. But for a man with a prostate cancer diagnosis, anywhere along that spectrum, from low risk, localized disease to aggressive, advanced metastatic disease, we always think there's opportunity for us to be getting better at the treatments we offer, whether that's making treatment more effective or delivering treatment with fewer side effects. And the way we figure out how to do those newer treatments is through clinical trials. So one thing I do just want to emphasize is that at Massey, we try to have clinical trial options available for patients across that spectrum of clinical situations. And so always worthwhile, if you have a cancer diagnosis, to ask your doctor if there might be a clinical trial option available. Now, each of these different types of treatment has advantages and disadvantages. And really what it comes down to is, for any one individual with a prostate cancer diagnosis, your treatment plan needs to be individualized. We have ways to adjust our treatments, tailor our treatments to make sure that whatever we are doing is in line with the goals, preferences of the person who's sitting in front of us. So always need to be trying to individualize our treatments.
Dr. Nelson?
Yes, ma'am.
While you were on that slide on treatment, what is HIFU, that acronym?
Yes, it's high intensity focused ultrasound. So it is using a special type of ultrasound machine to essentially ablate an area of tumor in the prostate itself. So it's an option for folks with localized prostate cancers.
Thank you.
So I guess before, going through treatment, talking about treatment options, coming up with that individualized plan, the first step is finding the cancer, making a cancer diagnosis. Like I said before, most patients with prostate cancer do not have any symptoms at the time of their diagnosis. The tumor is not causing trouble yet. And so there's oftentimes no symptom that pushes someone to come seek care. And that's why screening for prostate cancer is so important, is we want to be able to identify it before it is causing symptoms, before it has grown to the point where it can cause symptoms. So the primary way we screen for prostate cancer is a blood test called PSA, which stands for prostate specific antigen. So this is a protein made by the prostate gland, but also by prostate cancer cells. And as prostate cancer grows, it tends to release more of this PSA into the blood. One of the challenges with PSA is it's not a perfect test. There's no one PSA level that perfectly tells us if there is a cancer or not in the prostate. So there, for example, are folks who have an elevated prostate specific antigen, an elevated PSA, but they don't necessarily have a cancer. But it is our starting point. And once we have information from this blood test, in coordination usually with our urology colleagues, we work up that PSA. We do our due diligence to figure out, could there be a cancer there? So if the first step is this blood test to check a PSA, the second test would be to get an image of the prostate. So we want to get a scan to see if there is a suspicious spot on the prostate itself. Um, MRI machines have gotten better over the years, and now we have MRIs that are able to give us a good look at the prostate, and radiologists who do an excellent job of interpreting those scans to tell us whether or not there is cause for concern, whether or not there is a spot in the prostate we need to worry about. There's a chance you have someone with an elevated PSA who has an MRI of the prostate, and there's nothing of any concern. And you say, great, we'll go back to monitoring the PSA, repeat a scan in the future if we need to. If there is something of concern on the MRI, the next step would be a prostate biopsy. So that is a procedure to get a sample from the prostate itself. That can tell us whether or not a prostate cancer is present. And it can also give us information about the prostate cancer if it is there, something called a Gleason score, which is one way we measure whether a cancer looks less aggressive or more aggressive. I think a key point with the prostate biopsy is that these days a prostate biopsy should be targeted. So if you look at this picture on the right, the way prostate biopsy was historically done is what we call a template biopsy, where the doctor doing the procedure gets a sample from 12 spots throughout the prostate, trying to cover the gland in its entirety, try to increase your chances of finding a cancer. But it is certainly possible, like the image on the right here, that there could be a tumor that is not within one of those template sites. And you can miss a diagnosis by not actually biopsying the area of concern. So these days, when we're sending folks for prostate biopsy, we really want to make sure that the biopsy includes a targeted biopsy. That's where you actually confirm that the sample you're taking is from an area of concern on the MRI. If someone is diagnosed with a prostate cancer, oftentimes another step that we would think about is something called a PSMA PET scan. And that is an imaging test to see if there's any sign of cancer spreading elsewhere in the body. And once we have all of that information, then we would be able to sit down and put a plan together. One point I think is important to make is that before some of these imaging tests, oftentimes a standard part of prostate cancer screening was a digital rectal exam to see if there was a palpable lump or abnormality on the prostate. There are still times where a digital rectal exam may be necessary or helpful, but it is in general not mandatory. So, I've spoken to men, and I think very understandable, who've had reservations about getting screened for prostate cancer out of concern that getting screened for prostate cancer means you have to have a rectal exam. And that's not always the case. So that's the general process for getting screened for prostate cancer, what it might look like as you work through your test results. The next question is when? When should you start? Age is the major risk factor for prostate cancer. So there's been a lot of thought put into figuring out when is the right time to start screening for prostate cancer. Cancer screening is a shared decision between an individual and their doctor. So I think having a conversation with your doctor is important to figure out what makes sense for you individually. But in general, I would recommend that Black men start talking to their doctors about screening at age 40 because of that earlier rise in incidence. Men with a high-risk family history, so men who have brothers, fathers, grandfathers with a history of prostate cancer, or also women in the family with breast or ovarian cancer. Sometimes the genes involved in prostate cancer are also involved in those other types of cancer. Should be talking to their doctors about starting screening at age 40. And then the guidelines vary depending on where you look, but generally somewhere between 45 and 50 is what I would suggest for when to start screening otherwise. All right, I see we're pushing time a little bit. So let me get through this section on testicular cancer, and then I think we'll have a chance for questions after that. So as opposed to prostate cancer, which is the most common cancer diagnosis in men, testicular cancer, and specifically testicular germ cell tumors, are very rare. So whereas there were 300,000 some cases of prostate cancer in the United States per year, for testicular cancer, it's only around 10,000 cases per year. In Virginia, that translates into around 300 cases of testicular cancer in Virginia each year. But what's unique about testicular cancer is a leading cause of cancer in young adult men. So the average age at diagnosis with testicular cancer is somewhere in the early 30s. So this is an incidence curve based on age, similar to what we were looking at for prostate cancer before. But you can see that the peak for testicular cancer is somewhere in the early 30s, and then it really tapers off thereafter. So it is a rare cancer, but I think an important one, especially for young adult men. Most patients with testicular cancer will present with testicular swelling, oftentimes a painless lump or mass. Because testicular cancer is rare, there's no standard screening recommendation for it. But if you have clinical concern for testicular cancer, if there is swelling or a mass, it is easy to work up. The diagnostic test over here is an ultrasound. So it's a non-invasive imaging test to see if there is anything of concern that needs to be followed up on. Now, unfortunately, something we often see is that many of our patients who come in with testicular cancer are young, healthy. Cancer is not on their mind when they have something abnormal show up. And so often there is a many month-long delay between when something was first noticed and when they make it in to be evaluated and worked up. So certainly would encourage folks to reach out to their doctors, seek care, if you notice something abnormal. Testicular cancer treatment usually starts with a surgery to remove the testicular cancer. And then treatment options vary depending on whether it is a localized cancer or a more advanced cancer. The point of this figure is just to say that there are a lot of different treatment options, and it all comes back to individualizing treatment, making sure we have the right plan for the right patient. But it's important to emphasize that our goal of treatment of testicular cancer is always cure. Whether or not it is localized cancer or cancer that has spread, we are always treating testicular cancer to cure it. And these men will often have many years of life ahead of them. If you're diagnosed with a testicular cancer when you're 30 years old, you have decades of life ahead of you. And so survivorship becomes critical. There can be long-term complications, toxicities from the treatments that we give for this type of cancer. And so making sure that these men have appropriate supportive care, follow-up care, well after the cancer has been treated is very important. We're lucky here to have a survivorship program in Massey to help support these patients. All right, let's see. I think I'm going to skip over the androgen deprivation therapy to just a couple take-home points, and then would love to answer any questions. So from a take-home standpoint, I think important to recognize that prostate cancer, lung cancer, and colorectal cancer account for half of cancer diagnoses in men in the United States. That testicular cancer is rare, but it is a leading cancer diagnosis in young men. And then cancer risk factors differ from person to person, but I think you should at least be discussing cancer screening options as you approach your 40s. That's the right time to have that conversation and start making a plan that works for you. Thank you all.
Woo! Thank you, thank you, thank you. So as I stated before, the best and the brightest are here at Massey. And with that in mind, you'll see how our best and our brightest actually connect with you guys. So you've dropped questions in the chat the whole way throughout the presentation. We're excited about that. And so with that in mind, Dr. Melson, if you don't mind, we're going to get in and just go ahead and jump in.
Yes, please.
Perfect. So Gail Roberts House asks, is there any genetic testing that can be done that might indicate the possibility of one having prostate cancer in the future?
Yes. So there are, let's see, from a genetic test standpoint, I think the place to start is information about your family history. So there are genetic tests that can be done, for example, blood tests to see if you have one of these genes that is associated with prostate cancer, like the BRCA genes, the BRCA1 and 2 genes. Uh, but in general, um, we think about sending those tests or doing those tests in the context of a family history. So if we know that someone's dad had prostate cancer, uh, their dad's mom had a breast cancer, that would be an indicator to us that there could be one of these genes in a family and we should go looking for it. So I would say there are tests available, um, but understanding family history is a good starting point to figure out if one of those genetic tests makes sense.
Ooh, fabulous answer. Great. Thank you. Thank you. Thank you so much. And we do have genetic counselors here at Massey. I will say that as well. So if you're interested, please reach out to CLE. We can see how we can kind of help you on that journey. Um, Stephanie Carrington asks, can men have a low PSA and still have cancer?
Yes, it is possible. And so I guess a couple thoughts there. Um, there, person to person biology differs. And for whatever reason, some folks, their prostate gland just does not produce as much PSA, or their prostate cancer may not produce as much PSA. One thing that's helpful is the trend or change over time. So even if someone has a low level PSA, uh, if that level were to start increasing or change from a steady state to a jump up, even if the absolute level is on the lower side, that might be enough cause for concern to say we need to work this up. We need to get an MRI. We need to look into it. So, absolutely right. Sometimes the trajectory can be very helpful.
Perfect. Okay. Let's see. What question do we want to ask next? Okay. This is from our Con and VCU Health Hub watch party. So, are there any specific risk factors or other differences for trans feminine folks with a prostate on hormone replacement therapy?
Hmm. This is a very good question. Um,
Right.
I, I don't think I don't think there would be any specific risk factors. We say that anyone who has a prostate is at risk of prostate cancer. So as long as the individual has an intact prostate, we should be thinking about age, family history, uh, in the same way to determine cancer risk and screening recommendations. But anyone who has a prostate is at risk of prostate cancer, and I think should be discussing screening for prostate cancer.
Perfect. Great answer. And again, if you're looking for any more guidance with that, please feel free to reach out to us at Engage Massey. We'd be happy to kind of help you walk along that journey. Next question. Ooh, it's from Lauren Dane. If I'm saying your name incorrectly, please, my apologies. But they asked, I've heard several physicians say that PSA screening isn't the most specific test and could lead to unnecessary testing. So it's no longer recommended for regular screening. What is your opinion, slash, what is standard among urologists?
Yeah, so to be honest, I think you'll get different opinions from different folks. What I would say is that the PSA by itself is not a perfect test. So PSA can be made by the normal healthy prostate tissue and prostate cancer cells. So it is possible to have an elevated PSA that is benign. It's coming from healthy prostate tissue. And so if we were to take every man with an elevated PSA level and put them through a prostate biopsy, I do think that would be over testing. We would be doing more biopsy procedures than is really necessary. So that's where the follow-up of the PSA becomes really important. Not just what the number is, but is it changing over time? Do we see something suspicious on the MRI to make us more confident that there might be a cancer there? So you're absolutely right. I think if you're doing screening just with the PSA as a one number, either above or below a cutoff, it does have many limitations. If you check a PSA and then you take that information in the context of how it changes over time, whether or not there's something on an MRI to raise our concern, I still think it's a very valuable tool.
Insightful context. Thank you so much for again showing the nuance and acknowledging it. Next question is from Suzanne Brown. How's the Gleason score determined? Sorry.
Yeah, so a Gleason score is something that our pathologists help us with. So when they have a prostate biopsy, they are looking at the prostate cancer cells on a slide under the microscope, and they look at the appearance of those cells. Do they look very similar to healthy prostate tissue, or do they look very abnormal? And within that spectrum, they assign a number to it. And the Gleason score is actually composed of two numbers based on what they are seeing, what pattern of cancer cell growth they're seeing. So on the lower end would be a Gleason 6 cancer, meaning not terribly abnormal, not too dissimilar from healthy looking prostate tissue. On the other end would be a Gleason 10 cancer, where the cancer cells themselves and how they're growing is very abnormal, very bizarre, more aggressive looking. But the way the pathologist gets that score is by looking at the cancer itself under the microscope and describing to us what they see.
Ooh, insightful. So I hope you guys got a better idea of like what's going on, I think, behind the scenes when you're getting screened. Next question is from the Con/VCU Health Hub Watch Party. Can a special diet help reduce cancer progression during treatment if you've been diagnosed with cancer?
So I think it's a challenging question. Diet in general is so hard to study because there are just so many factors involved. In general, what I tell my patients is I don't think I can recommend one diet that would treat your cancer or control your cancer, but I know that there are certain diets that support your overall health. Um, you know, diets that reduce your risk of heart disease, reduce your risk of diabetes. And whenever we're talking about cancer treatment, the better shape someone is from an overall health standpoint, the better we expect them to do as they're going through cancer treatment itself. And so I don't think there's a cancer-specific diet, but any dietary changes or behaviors you can follow to promote your overall health will be good from a cancer treatment standpoint too.
Phenomenal answers always. Next question is from Dr. Herbert Ponder. And so I think the question is that is it a goal to cure all cancers or just testicular cancer? And Dr. Ponder, if I said that wrong, please feel free to chime in, but I think that's what you would say.
Yeah, so I think ideally we would love to be able to cure all cancers. There are some cancers that once they have spread to a distant part in the body, we can't cure them. We can slow them down, we can manage them, control them, but we can't totally eradicate them. So for example, prostate cancer, if it has spread to the bones, we don't have a treatment that can cure it, but we can control it, help men live longer, live well. The reason I emphasize it with the testicular cancer is a bit unique in that sense that if it has spread to distant parts in the body, it can be cured with things like chemotherapy alone. Now, I'm harping on it, but that's why we do think screening is important and can be valuable, is that, we would love to find more of these cancers before they have the opportunity to progress to an incurable stage.
Fabulous answer. And then we'll take this question from the Con and VCU Health Hub Watch Party. What are your thoughts on clinical trials?
Yes, so I will always support someone who is interested in taking part in a well-designed clinical trial. And I think the well-designed part
I love that.
is very important. You know, we consider certain types of treatment standard of care for a reason. They're standard of care because they have been proven to be effective or the best option available to us. If someone is talking about taking part in a clinical trial, we're often doing something that is different from the standard of care. And so if we're ever offering someone something different than the standard of care, we need to have good evidence, good confidence that what we're offering is just as good, if not better, than what the standard of care would be. So um, I think patients participating in clinical trials is how we learn to be better in terms of our treatment and how we take care of patients. Would always support patients looking for clinical trials. And then if I have a patient in front of me who's considering one, I want to make sure that the clinical trial is a good one, that what we're discussing, we have good reason to believe is just as effective, if not better, than what they would otherwise be getting as treatment.
Perfect. And to the VCU team, I know you guys asked some questions. I'm sorry, we'll get to those later. I got to put me first. So this is the last question, but again, I think this is a driving question. I think will leave us with something home to chew on. And so for me personally, to you, my question is, how do you feel cultural expectations of masculinity affect cancer outcomes? Or how have you noticed that I think the cultural expectations we have as men really affect how we go about cancer and outcomes we experience?
Yeah, yeah. Um, let's see, it can show up in so many different ways. I will say any individual's cancer diagnosis, cancer treatment plan, experience with cancer varies one person to the next. Um, I often have men in my clinic who I think carry a lot of that burden on themselves, are maybe more hesitant to reach out about side effects of treatment, looking for support as they're going through their treatment. It's hard to put a broad label on it, but I think it's important to note that anyone going through cancer treatment, including men, needs support. It can be a hard road. We do have a very nice group in Massey who do a men's cancer support group that meets regularly to be an avenue for support that's separate from the clinic, outside of the doctors and the nurses who are taking care of it. So,
That was a phenomenal answer. So we're going to take you off the hot seat. And I just want to thank you so much again on behalf of the Office of Community Engagement, every attendee, for just coming, sharing your expertise with us, being so willing and so open to participate in conversation. And as you can see from the hearts going over the screen, the crowd really enjoyed you. So thank you for connecting with us, Dr. Melsa.
all right. No, thank you all so much for having me. And please, if anyone has questions after or wants to follow up, please reach out.
Yes. Yay. Absolutely. All right, all right. Go ahead. Give them a nice thank you, guys. Okay, send them off correctly, please. Show them we treat our guests nicely here. All right. And so now that we're running into the end, and I know how some of y'all like to do, and y'all be sneaking off. To the left right here, you will see a QR code under our hearts of the post-forum survey and evaluation. So you guys, I noticed that you guys do the pre. The post is so important. It's really how we figure out how you guys felt about it. How can we grow? What did we glow in this session? What would you guys like to see? Again, your voice in all of this matters. It's not an optional piece, it's a pivotal piece. So if you can, please scan that QR code or click the link in the chat, fill out the post form survey before you leave. Or if you forget, we're gonna send it out later. But please fill that out. It's super important. Next month I'm gonna try to bring and see how many people filled out, and we'll kind of talk about that. If you need to contact us, you can contact us at engagemassey@vcu.edu or by phone at 804-628-0896 if you have any questions about the forum, questions about the post-forum survey, or anything just for Engage COE as general. Next, we talked about some of these screeners. If you or someone you know or love is looking to get screened, we do have three questionnaires that'll kind of help you on that journey and tell you about your eligibility status for prostate, lung, and colorectal cancer. So we're encouraging you, if you're curious about your eligibility status, if you're curious about what type of questions you would ask for something like that, please scan these or click the link in the chat to do that. Or you can email us at Engage Massey, and we'd be happy to kind of send that to you. Connect with Massey. So, again, we have our one-stop shop all the way here to the left, our COE Linktree resources, which again has a plethora of resources for you to be able to access on your own time, if you need that. So that's to the left. In the middle, you will see a QR code for requesting Massey support at your events. So if you're looking to have Massey COE at your event, if you're looking to have us, if you're looking for some materials, you can scan that middle QR code and you can kind of request that from us, and somebody from the COE would reach out to you and kind of triage that with you. And then third, to the far right, we have Volunteer with Massey. So we have an exciting announcement coming up with that following up. But if you're interested in volunteering with Massey, I encourage you to scan that QR code and fill out our volunteer portal. And if you can't access any of these, email us or call us. And then we have something a little bit different next month. So as you see for the save the date, we actually have the topic being a listening session. So I've said it time and time again, and I've kind of said, your voice is a pivotal part of this. Our conversation together is what makes this happen, but we really, really mean that. And so, with that being in mind, we've kind of started in November. We're finally at July. I think we're at a point now where we can kind of check back in and kind of see how things are going. So, if you kind of attended every other session where you kind of listen to people talk to you, this session in July is meant for you to talk to us. So I'm encouraging you guys, and I want to see the same amount of numbers, so please come out to the listening session and support. I really want to hear about how things are going. I really want to share with you some insights that we have that we were able to collect through this, and we really want to decide what is the next steps moving forward. Our first year anniversary will be in November, so you already know that's huge, and we'll be in the year two. And so we really want to talk about how do we want to move together as this community, because I'm calling us a community together. How are we moving together as a community to kind of move this conversation forward regarding cancer and keeping it exciting and interesting for us all, and that we feel like we're learning something new and actually, again, reaching and addressing the needs of our specific communities. And if with that being said, we'll see you next month. Thanks for connecting.